As a young citizen of India, armed with technology, knowledge, and love for my nation, with a vision of transforming India into a developed nation, I am joining Shobhit University. What about you?
Very good morning to all the participants from India and abroad. Shobhit Institute of Engineering and Technology Meerut, a NAC accredited with A grade deemed to be university, and its centers of excellence, Center for Agricultural Informatics and E-Governance Research Studies, and the Center for Agribusiness and Disaster Management Studies, will extend greetings to all the participants. Today is Ram Navami. Greetings to all the participants from India and abroad who are attending today's national webinar series on doubling farmers' income by 2022. And the period 2022 is ending today of the financial year 2022-23. So I'm very happy to have this program on the last day of the period, doubling farmers' income by 2022. And today is 30th March 2023, and on the webinar topic is on digital health informatics network value chain in tribal villages, a case study from Palghar district, Maharashtra, under the title Smart Tribal Farming, Integrated Farm Health, Farmer Health, Plant Health, Animal Health, Soil Health, Water Health, Fish Health, and Environmental Health. On behalf of the Honorable Chancellor, Honorable Vice Chancellor, faculty members of the university, and on my behalf, and as Professor Emeritus and Chairman of Centers of Excellence, Center for Agricultural Informatics and E-Governance Research Studies, Center for Agribusiness and Disaster Management Studies, Center for Informatics Development Solutions and Application, Center for Industry 4.0 Technology Studies and Application, and Center for Health Informatics and Computing. Let me welcome today's guest speaker to deliver the talk in 110th edition of the National Webinar Series, Dr. Suresh Sarvadekar. Good morning, sir. And he is head Keshav Shruti Gram Swasthya Project, Mumbai. And he was also a highly recognized medical professional, worked with Ministry of Medical Education and Health, Government of Maharashtra. I wish to inform the participants and the speaker that the university regularly conducts two webinar series, namely National Webinar Series on Doubling Farmers' Income by 2022, Atmanirbhar Bharat in Agriculture, and International Webinar Series on Open Source Digital Technologies towards Self-Reliant India, Atmanirbhar Bharat, on every Saturday. Under this webinar series, so far the university has organized 109 webinars on the topic. This is the only university in the whole world having agriculture as a use case for technology adoption and get involved in the policy for formulation of doubling farmers' income by 2022 Committee of Government of India, and also as is devised ways and means to propagate for operationalization of the recommendations of the popularly known as Dr. Ashok Dalwai Committee report on doubling farmers' income by 2022. The university was closely associated for Volume 11 and Volume 3. Volume 12B, in the Volume 12B is Digital Technology in Agriculture. I chaired those subgroups. And under this webinar series, 109 webinars have been organized on various important topics. And it is a big list, 109 list, it will take more time, but I will read it out. Some of the, important one which is relevant to this, today's topic. Model Village Development Program, case study from Maharashtra. Model Village Development Program, case study from Maharashtra, addressed by Padma Shri Papat Rao Pahuji Power, former Sarpanch, Hiware Bazar Gram Panchayat, Ahmednagar District, and Executive Director, State Government's Model Village Program, State of Maharashtra, India, on 30th December 2021. I think there is an internet connection problem, and our guest speaker will join, meanwhile. And farmers collective with value addition, powerful business model for income increase for small and marginal farmers, sustainable food production, impacting life through livelihood contribution to rural livelihoods, case studies from developing countries, you know, you know, case studies from developing countries, and agriculture value chain challenges and opportunities, and Swas Palekar's natural farming, future of farming rooted in Indian tradition. And there are, very important topic which we talked about it. And last week there is on, on 11, on we had a talk by smart tribal farming steps towards operationalization of doubling farmers' income by 2022 committee recommendation in Jawad Hills in Tamil Nadu by Sanjay Kumar Chaudharyji, and he is initiating in collaboration with the Shobhit Institute of Engineering and Technology to see that the Jawad Hills is a climate resilient smart hill agriculture by 2050. And as a first step is initiated smart tribal farming, operationalization of doubling farmers' income by 2022 committee recommendation. And it is very important. He has delivered the talk on 16th March 2023. And today is the talk will be by Dr. Suresh Sarvadeka on this very important topic. To develop any sector of economy, a nation essentially needs four main synchronized intervention, namely enabling policy environment, state-of-the-art technology, financing mechanism, and entrepreneurship capacity. These four issues will be seen in today's presentation. India is said to be a land of villages. Acharya Vinoba Bhave said, India is largely an agricultural country and a country of villages having more than 6.25 lakh villages. And out of these 6.25 lakh villages, about 1.45 lakh villages have been having tribal population. And out of 40,000 villages, where more than 50% of the population are tribal people. And farmers of India are facing multidimensional problems: price fluctuation, debt, lack of infrastructure, and weather. And towards this one, how to introduce digitalization to help 14.5 crores operational holders, out of which 85% to 90% are small and marginal farmers. How to facilitate them to integrate with the global value chain. And the committee set up by Government of India in 2016 on the title Doubling Farmers' Income by 2022, which submitted its report on 2018. I was closely associated as a group leader for Volume 12B and Volume 11. Volume 11 talks about empowering the farmers through extension and knowledge dissemination. And Volume 12B, Digital Technology and Agriculture. These recommendations are very important for today's topic. And first recommendation is digitalized agriculture, digital technology and innovation in agriculture, synergization of various government schemes, be it central government scheme or state government scheme or local body scheme, should synergize at the village level. For transformational reforms in agriculture sector through smart irrigated farming, smart rainfed farming, and smart tribal farming, digitalized agromet advisories and agricultural risk management solutions, digitalized agricultural resources information system and micro level planning for achieving smart village and smart farming, digitalized value chain for about 400 agriculture commodities, digitalized access to inputs, technology, knowledge, skill, agricultural finance, credit, marketing, and agribusiness management to farmers, and digitalized integrated and water management system per drop more crop. And the last one is very important. We have to have a digitized farm health management system for a reduction of farmers' loss. This is an integrated approach. Human health, that is farmer health, and then plant health, animal health, soil health, water health, fish health, and environmental health. The health aspect is of integrated nature at the grassroots level. And today's with the technology, it's very important. And one aspect, Dr. Suresh Sarvadekar has operationalized in more than 30 tribal villages in Palghar district. Today he will talk on that. And we have an Atmanirbhar Bharat. It is a vision of our Honorable Prime Minister Narendra Modi of making India a self-reliant nation, rested on 5 I's: intent, inclusion, investment, infrastructure, and innovation. Based on 5 pillars: quantum jump in economy, infrastructure, what that represents modern India, system 21st century technology driven, vibrant demography, and a demand whereby the strength of our demand and supply chain should be utilized to full capacity. And we also have an Amrit call led up to 100 for next 25 years, how India should be, how India should do to be new India at 2047. And India's budget 2023-24 talks about Saptarishi priorities. And one is that the digital public infrastructure for agriculture, which should be built on open source, open standard, and interoperable public good that will help develop farmer-centric solutions for crop planning. And it is a landmark step towards Modi's government's commitments towards net zero 2070. And this also talks about revolutionizing the sector, agricultural sector, by encouraging agri-tech startups and natural farming, agri-startups and natural farming. And this will have a course corrective directional shift through the onset of reverse migrations. And we have 17 sustainable development goals and 169 targets to be achieved. And smart tribal farming is a very important component. And this has to be integrated with the global agriculture value chain. This will improve livelihood opportunities through sustainable growth and development. Ministry of Tribal Affairs have initiated developmental initiatives in tribal-dominated states to start a phased transformation program across 1.45 lakh villages with more than 15% of the total population to convert them into model villages, model villages. And now we talk about smart model villages. The new program, Pradhan Mantri Adi Adarsh Gram Yojana, would be initiated across India in multiple phases. The first phase will include 36,428 villages with at least 50% tribal population. And main objective of the ministry is to provide more focused approach on the integrated socio-economic development of the scheduled tribes. There is a need for tribal digital platform for sustainable development and growth. This is where the Shobhit Institute of Engineering Technology, with these 2 centers of excellence, Center for Agricultural Informatics and E-Governance Research Studies and Center for Agribusiness and Disaster Management Studies, have initiated various pilot projects in tribal villages across 12 states, starting from Gujarat, Maharashtra, Madhya Pradesh, Rajasthan, Chhattisgarh, Jharkhand, Odisha, Andhra Pradesh, Telangana, Karnataka, Tamil Nadu, and Kerala. Smart Tribal Village is a digital village, and it is very important to have a smart tribal farming. And also that, it will operationalize the Dr. Ashok Dalwai Committee report on recommendation on digital technology in agriculture, 7 mission mode programs. In Orissa, we have undertaken a cluster of 10 villages in Mayurbhanj district. In Jharkhand, we have identified an NGO to work in the district of Kumla district. And Chhattisgarh, we have identified an NGO to work in Gorba district. In Andhra Pradesh, Tirupati district and Kurnool district, that is comes under Rayalaseema region. And Telangana, Suryapet district. Tamil Nadu, Jawad Hills and Coimbatore district. Kerala, Wayanad district. And Karnataka, Koppal, Devangre and Samraj Nagar district. Madhya Pradesh, Betul district and Maharashtra, Palghar district. And in Gujarat and Rajasthan, the cluster of 10 tribal villages are under identification. During this budget, the government of India has launched a very big scheme, Pradhan Mantri PVTG Development Mission, that is particularly vulnerable tribal group development mission. It is announced in the India's budget 2023-24 to focus on improving the overall socio-economic conditions of 75 particularly tribal groups across the country who live in around 31,000 villages of India's 18 states and 1 union territory. The government has allocated rupees 15,000 crores to be spent on development of tribals. This mission will have components from Ministry of Rural Development, Ministry of Water Resources, Ministry of Education, and Ministry of Women and Child Development, and Ministry of Health. And this is very important. This is where this project, the Digital Health Informatics Network Value Chain in Tribal Villages, this can be scaled up to throughout the country in these 18 states and 1 union territory, on small, health informatics network value chain. And health informatics network value chain has got components such as public health system, plant health system, animal health system, and fish health system, soil health system, water quality system, and air quality and environmental situation, environmental conditions. Adoption of smart village framework facilitates creation of village chain value chain networks for sustainable integration. And health informatics, as established, uses information technology to organize and analyze health records to improve healthcare outcome. And establishing health informatics network value chain will enable no lockdown process on account of any pandemic situation in future through big data analytics. And it will facilitate quarantine only those who face problem in such a situation. Building One Health ecosystem, role of digital architecture. One Health is a collaborative, multi-sectoral, and transdisciplinary approach, working at the local, regional, national, and global level, with a goal of achieving optimal health outcomes, recognizing the interconnection between people, animal, plants, and their shared environment. And human health, it is closely linked with food security and food safety. Plant nutrition is closely linked with nutrient cycling and soil fertility. And plant protection is closely related with pesticides and diseases. And environmental health is closely related with microbiomes, microbial diversity, and multiple functions. This has to be seen in totality. And we also need to have, the One Digital Health is a proposed unified structure. The conceptual framework of One Digital Health steering wheel is built around 2 keys: One Health and Digital Health. It means that you have to have a digital twin program. One Health, health informatics has to be converted into digital health informatics. So This digital twin program is being advocated in Industry 4.0 technology studies, technology solutions, and also Agriculture 4.0. And now it is being promoted that based on the data which collected from the patients, then we have to build up digital health in the lab and one health in the form of that what Dr. Suresh Sarvadekar has done it. So one health and digital health will be interoperable. That will become digital twin program in the health aspect. Emerging technologies are 3D printing, advanced analytics, advanced materials, advanced robotics, advanced artificial intelligence, biotechnology, biomanufacturing, blockchain, cybersecurity, energy storage, digital design, and high performance computing, and interface of things and internet of things. Interface of things and internet of things. And under the national webinar series on doubling farmers' income by 2022, we have organized following webinars: sustainable soil and land management for climate smart agriculture, Octosol organic humic solutions for increasing crop yields and quality while increasing farm income and improving soil health, manufacture and application of biochar for increased soil fertility and crop productivity, artificial intelligence and data analytics to ensure optimal nutrition in the soil, harvested food that minimizes human disease. This research work has to be undertaken. Artificial intelligence and data analytics to ensure optimal nutrition in the soil, harvested food that minimizes human disease, animal health industry, quality, innovation, talent, and technology have power to transform, agricultural resources information system, and micro level planning for enhancing farm health, key to achieving the doubling farmers' income by 2022 agenda put forth. Role of artificial intelligence in health care, current developments in diagnosis and vaccine research, health informatics network value chain, e-health system and beyond, health informatics network value chain, early childhood development and learning, health informatics network value chain, clinical AI, interface between machine learning and health informatics, health informatics network value chain, importance of social medicine and community health in the times of health emergency by Professor Sankamitra Sheel Acharya, Jawaharlal Nehru University, Delhi. Health informatics network value chain, medical outreach, challenges versus potential by Mr. Rajendra Kakrala Vesana in the district of Nilgiris, Tamil Nadu. Doubling farmers' income, imperatives of plant health informatics network, health informatics network value chain, National Animal Disease Reporting System, NADRS 2012 and beyond. Animal Health Network Value Chain, building of one health ecosystem. Role of digital architecture by Dr. Sindhura Kanapati, visiting Principal Scientific Advisor Fellow, Office of the Principal Scientific Advisor to Government of India. Health Informatics Network Value Chain, digital health analytics, leading to digital twin for better health care. According to the synopsis of the guest speaker, he is involved in the project in the Palghar district, Maharashtra, in about 30 tribal villages. And he says the villages are living in two health zones, namely red alert and yellow alert health zones. I have therefore developed a model titled Complete Solution for Rural Health Problems at the doorsteps of villages through 1. Active community participation, use of digital tools, self-reliant health insurance scheme. And this model is now being effectively tested in 31 villages in Palghar district, state of Maharashtra. The project uses of modern digital tools for early diagnosis and for collection and storage of health records by launching of QR code based wearable health locket. QR code based wearable health locket. The broad outcomes will include reduction in time to diagnosis, reduction in cost to diagnosis, and continuity of medical treatment. This model is useful for all villages, but focused specifically for tribal villages. Now let us turn to the address by Dr. Suresh Sarvadekar, head Keshav Shruti Kram Swasthya Project, Mumbai, and former, Deputy Director, Ministry of Medical Education and Health, Government of Maharashtra, Mumbai, on a very important topic, digital health informatics network value chain in tribal villages. Case study from Palghar district, Maharashtra. Today's topic will motivate and galvanize the participants watching over telecast through facebook.com/Shobhit University India, or youtube.com/Shobhit University in, or linkedin.com/company/Shobhit-University for establishing startups, physical plus digital infrastructure in association with Keshav Shruti Kram Panchayat Kram Swasthya Project. Keshav Shruti Gram Swasthya Project, facilitating agriculture and rural transformation in India's tribal villages. Let us unlock the opportunities in India at the earliest. Let me introduce the guest speaker to the audience. Mr. Manish. Dr. Suresh Sarvadekar, head Keshav Shruti Gram Swasthya Project, Mumbai, and former Deputy Director, Minister of Medical Education and Health, Government of Maharashtra, Mumbai. Before superannuation in 2012, Dr. Suresh Sarvadekar has worked as an Assistant Director and Deputy Director in the Ministry of Medical Education and Health, Government of Maharashtra, and also at Ministry of Health, State of Bahrain, and Professor in Pharmacology at various colleges. After retirement, Dr. Suresh Sarvadekar has been Senior Consultant for the Ministry of Defense, Government of India, and also for Government of Telangana and various corporate and government hospitals, and also for Health Express Division of the Indian Express, and now as Honorary Consultant for Institute of Medical Sciences, Banaras Hindu University, Varanasi. Currently, Dr. Suresh Sarvadekar is involved as head Keshav Shruti Gram Swasthya Project in operationalizing in 30 villages in Palghar district, state of Maharashtra for the last 2 years. Dr. Suresh Sarvadekar had hands-on experience in state-run hospitals and at the state level regarding reforms in state policies and strategies with respect to procurement of hospital supplies and equipments. Has been passionate about positive health promotion in healthcare sector rather than negative disease promotion, and is known for his contribution towards education and empowerment of masses regarding proper use of funds on use of medicine and proper use of medicine per se. With this, I invite Dr. Sarvadekar to participate in the national webinar series on doubling farmers' income by 2022 on 110th edition to talk on digital health informatics network value chain in tribal villages. Case study from Palghar district, Maharashtra. Over to you, sir. Thank you.
Thank you, sir. Thank you for giving this opportunity for sharing the knowledge and experience with a lot of masses. So after my retirement, that is my main passion, to whatever we have learned, giving back to the society. That is the idea. So last week, we presented this project to the Asian African Conference also. They also liked it. So today I will talk in short about what it is actually and what we are doing and what is the impact that we are. So can we go on the slides, please?
Sir, please upload the slide.
Mr. Manish, can you?
Sir, please upload the file.
Okay, okay, 1 minute. Is it done? Hello?
Yes.
Yeah. So let us start with this topic. Today, we have seen that the digital health is coming in a big way, and technology is like a pandemic entering in each and every sector. But use of technology for the populations in health, as Dr. Moni said, that in agriculture, I mean, is not that much concentrated. So in that we can say endeavor, we try to use the with the help of brand care, which is our software consultant. Next. So the chapters that I will be presenting is sorry. Introduction to the tribal belt and their health life,
You have to move to the. Okay.
problem statement, solution, and outcome. So these will be the headings. First, introduction to the tribal belt and their life. Tribal life is a means of livelihood. We'll see what are their lives of means of livelihood. What is their education status? What is the nutrition security and health focus? So let us see one by after. Now the national health systems resources found that according to the census of India 2011, scheduled tribes population numbers around 104 million, out of which 8.6 of the country's total population. In India, the tribal inhabitants are scattered across the large areas with poor access to basic health necessities. Therefore, it is observed that tribal people have remained marginal with poor health, unmet needs and a poor population provider ratio. The various factors attributed to poor tribal health outcomes in India are habitat, difficult terrain, ecological variable niches, illiteracy, poverty, isolation, and the other factors. So, when you look at that, the difference in terrain environment, because they are going into the hill area, so each systems and culture each state of healthcare needs. They have different healthcare needs than the normal rural care population. So what is that? The 10 problems that are specific to tribal wealth, which has been identified by the National Scheduled Tribe project. So those are malaria, malnutrition, child mortality.
Can you go to the previous slide?
What
No,
happened?
don't rush through that. Alone. Please, please
Ah,
don't rush through. Ah, go to the previous slide.
okay.
No, it's you know.
Malnutrition.
I think you are from second slide onwards. You start rushing. Don't rush through that.
Ah,
Alone.
malaria,
Go back.
malnutrition, child mortality, maternal health problems, family planning and infertility, addiction and mental health issues, genetic disease like sickle cell anemia and other genetic, animal bites like snakes and other animals, and accidents, low health literacy, and poor health of tribal children at ashram shalas. So these are the 10, what you can say, problems that have been identified by the highlights, the report of National Scheduled Tribes report. So it says that highlights of the report are significant lack of healthcare human resources. Healthcare professionals, doctors view posting in the tribal areas as a punishment of sort and are hesitant to go, much less stay there. Then second is near absence of health record. The current public healthcare system uses ASHAs and PSC staff for health data collection. However, the results are very poor due to inadequate training, poor skills of ASHAs, insufficient motivation, inadequate support, supervision, irregular payment of incentives, etc., and absence of adequate evaluation and monitoring. So these two, and third is total absence of community participation. Now, ASHAs have been selected though from the community from that village also, but they are selected for a particular 3 to 4 villages together. What we have developed, the community participation has to have from the same village. Now, look at the Palghar district. It is the 36th district in the state. It is spread between the west coast of the Arabian Sea and the Sahyadri Mountains roads. This separate districts form on. It was previously with the Thane district merged. Now it has been from the 1st of August. It is separated. It comprises 8 tahsils, namely Mokhada, Talasari, Vasai, Vikramgarh, Jawar, and Palghar and Dahanwada. Now I am sitting at Vikramgarh, from where I am delivering my lecture. So the total population is 30 lakhs, out of which 37% living in small helmets called padas. Tribal groups are Wardi, Katkari, Malar, Kodi, etc. The main occupation is farming and migration labor. Crops are grown only in one season. And crops chiefly rice and finger millet, what we call it as a natsni. But that is also now come as, you can say, less. Now, another peculiarity of this Palghar district is art. They have got with this Warli
Just
paintings
don't,
and Tarpa
Dr.
dance.
Sureshji, don't rush
Ah,
through that. No, let the people also watch, those who are watching it. Okay, go to the.
okay.
Okay. Ah.
Now, Warli paintings use a set of basic geometrical shapes such as circle, triangles, and squares, which represent nature. The most important aspect of these paintings is that doesn't depict mythological characters like images of deities, but social life. So they use the basic shapes like circles, triangles, and squares. The origin of Warli art can be traced around 3000 BC, but was not known until 1970s. Warli artists use their clay huts as their backdrop for their. So usually on their huts they paint this. There is another. They have got a tarpa dance. You can see the person who is using instrument that is called tarpa. The tarpa is a trumpet-like instrument and is played in turns by different village men. So this is typical of this Palghar district tarpa and Warli paintings. Now, health education and general conditions. Highest under 6 mortality, and it is especially in COVID, we have found that highest in the mortality is 300 per thousand, which is the highest. National average is only 27, and it has increased after COVID pandemic. 59% of the children are stunted, 20% wasted, 53% are underweight. And again, it has increased after COVID. 50% girls get married before the age of 18. Once they complete their 10th, they are married and sent to their, what you can say, in-laws. 95% live in the kacha house. Their houses are not also pakka. 90% use wood as a fuel. So don't have gas connections. When I ask about them, why they don't have kacha, pakka house and fuel, this is because they don't have their ownership on the land. They were in the forests. So for all national schemes, they need a ownership. Then only they can go to the Pradhan Mantri housing scheme, Pradhan Mantri, you can say, what is that, Ayushman Bhav. But that is not with them. So that is the basic requirement required. So they are left unattended. So over 40% are landless. And male and female literacy is also only male it is 53% and female it is 46%. The mother mortality rate is 18 to 20, and which is again increased after COVID. Almost all the tribals in Palghar work as a laborers. Illiteracy, extreme poverty, lack of livelihood options, lack of accessible healthcare, and poor health of mothers are major reasons of undernourishment of children. Now, our observations on current situation of healthcare, which did one and a half year back, that shows that stunting in children and low BMI in adults is very common. Lowest nutritional security. Food intake of proteins, calories, vitamins have decreased in last decade due to changing food habits to junk fast foods. So you can find Chinese stalls are now inaugurated in these villages also. They have entered into this and they most of the children they eat this what you can say vapors and all those. So the things which are not needed they are made available at the remote areas, but what is needed is not available. That is the actually you can say paradox. high proportion of respiratory, mental, neurological, and musculoskeletal conditions. The incidence of congenital gerosis, ear discharge, dental caries are also alarming. This is because of lack of sanitation and hygiene. Their water is not clean water, drinking water is not clean water. Even they don't have proper facilities for their, you can say, taking bath. They will go into the wells, and they will take the bath with wearing the clothes only. So that will not allow to clean the whole body. Even in case of women, we can see that they are not having these closed bathrooms. So they will be also again using some clothes on their body and then taking bath. This is really very pathetic, and we need to work on it. The bathrooms for especially female should be closed so that they can completely remove the clothes and clean their body. But that is not taken care. Even in case of this is very important, and that is the main area where sanitations they are getting this genital diseases and all those. Then there is a high incidence of tobacco and alcohol addiction, resulting in mental and social and family. This is mainly because of their economic status. They are economically handicapped. So whatever today they get around 230, they will use into the tobacco and alcohol. So that is the so when I asked them, but you can use it for your health and other, they said that we don't know what tomorrow will happen. So whatever available today, we enjoy it. So there is a huge gap in healthcare seeking in tribal. You know that there is primary healthcare centers, then health services. Then they are forced them to expand their limited resources. They are not able to meet the healthcare expenditures. Most of the national health schemes and other national programs have not reached tribal populations. Many don't have own land that we have seen pakka house, toilets, and gas as a fuel, and even closed bathrooms. Now, some of the positive findings that I found that they are good early and regular breastfeeding practices, and they will continue breastfeeding practices, not like our mothers in you can say metro cities. They will stop and push on to the ready-made you can say diets or milk. Then there is the absence of sex determination during pregnancy. This is also remarkable. They don't go for sex determination. Yeah, and there is no idea like that there is a male child prominence or they want male child. Then there is a good gender equality. We can see in an active participation and encouraging participation of women. Women, they are participated so much that in one of the photos you can see they come with their kids, and one the women will take care of the kid, and this, so they are very interested to come up in a community participation. Then the problem statement is poor economy, poor health literacy, poor health parameters, poor healthcare and services leading to poor or non-existent health records, and consequently no treatment and poor health outcomes. So this all starts with all this poverty at each and every level, not only at the level of economy, but health literacy, health parameters, healthcare services. So that need to be tackled very precisely. Now, what can be done to improve the state of tribal healthcare? What is needed is active community participation and collection of health data. Because if we work with the communities, we will find that tribal youth are an excellent resources, and inducting them into the healthcare will be a feasible, sustainable, long-term solution. Like we have seen in case of our healthcare couples. So when we are giving some nominal amounts to them as around 2,500, but their participation is amazing. We don't lose from the active participation project. But the primary aims of our project were to reach the unreached, then to meet their unmet needs by their active participation and make them self-reliant. So these are the primary. And for that, use of modern technology and digitalizations are very much essential. And for collection and storage of the data and health records, this is very, very important. Now, the part third, what are the solutions? Like Keshav Srishti is a non-profit organization established in the year 1984 at Uttan village, Bharinder.
I think internet disconnection. He is talking from a tribal village. Please wait. He will get connected. So, dear participants, this presentation is very important, and he is joined. He's joined. It's a very important presentation, and
I
please,
got disconnected.
Tracy, no problem.
Sir,
No
I have to again
Please get,
upload that.
yeah,
Yes, sir.
Huh?
yeah,
Yes, sir.
I have
please
to
Again.
again upload.
Yes, sir.
upload and go to that. And it is a very important, he is uploading once again, it's a very important topic. He talks about, that, he listed out, that the situations of the current healthcare situation, and also some positive findings, and the problem statement which he has listed out
Yeah.
is very important. Poverty at all levels, and poor economy, poor health literacy, poor health parameters, and poor health services, and poor or non-existent health records, and consequently no treatment, and poor health outcomes. And this is the first time I'm hearing that it's a ground truth which is coming out. Yeah, you can move on. That, Dr. Surya is good.
Yeah.
Yeah.
Why it is going back?
Yeah, coming.
It's going back.
Yeah, Mr. Manish, can you just help?
It is going back.
I think you come back once again. Allow.
Sir, I am changing. Let me know on which slide you needed.
Okay.
Sir, you leave it, sir. Which slide you need, sir?
Next.
I don't know. It is going back.
Yeah, Mr. Manish, you can correct it
Sir,
to the correct. Yeah, Dr.
Suresh, kindly leave, sir. I am changing. So this is slide number 9.
No, we have to go ahead.
Sir,
Go ahead.
please you leave. Sir, you please leave, sir. I am doing, sir. We were on slide number 11 now.
Huh? I am not doing anything.
I am doing, sir. Just let me know when we have to stop.
Yeah.
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 Here we go.
This is.
Okay, sir.
Huh. So what is needed is active community participation and collection of health data. Because we work with the communities, I told you that their active participation is amazing. they, as I told you, women come with the kids when they are pregnant. They come. So this is really amazing. There are primary aims. That's why we are is to reach the unreached, to meet their unmet needs by their active participation, and make them self-reliant with the use of modern technology for early diagnosis and for collection and circulation data. So technology is used at two places: early diagnosis and healthcare data. Now, what are the solutions? Now, I had done this with the Yashosh Srishti. So we started this in 87, and since last 3 years, they have started with Gram Vikas Yojana in Palghar districts, where we are working with the tribals through better resources management in water, agriculture, and empowerment through the local handicraft and tourism. It is not only health. Health has been started when I joined them in the last 1.5 years. Before that, they were into the water conservation, agriculture, and empowerment through the local. This. The Keshav Srushti Gram Swasthya Yojana. After I joined, we launched it on 1st January of 21. So the main targets are, as I told you, empowerment, self-reliance, and health data collections. Providing care through empowerment and self-reliance model, delegation of medical roles and skills. Here, this is very important. Every time you don't need a doctor for simple things, because now all the digital instruments are available at home also. You can take your blood pressure, blood glucose. So here we are using those instruments which are digital. So that's all of digital delegation of the medical roles to the skill community. Massive efforts to impart literacy. This is very important because they don't know so many things. Importance of cleanliness, sanitation. The full community participation, planning, accountability, and its highest priority. We call them, have a meeting with them. It is not that we bring and impose them. Always participated in planning, accountability. We use the enabling technology as a
Sureshji, you can switch off the video and then audio will be very clear. You can switch off the video because there is audio is not coming properly. You can switch off the video and then audio will come automatically. The bandwidth can be effectively utilized. I think he is facing some internet issue. He will join, and it's is talking about what can be done to improve the state of tribal health care. And what is needed is active community participation and collection of health data. Because if we work with the communities, we will find that tribal youths are excellent resources, and inducting them into healthcare will be a more feasible and sustainable and long-term solutions. And therefore, the primary aim of our project are to reach the unreached and help them and to meet their unmet needs by their active participation and make them self-reliant. This is what he talked of late. You can continue with your presentation, Dr. Suresh.
Yeah. So I have to get back to that slide. So if
you can while talking, you can switch off your video and only audio let it be on, so that but you got you disconnected.
Switch it up. Yeah. Those slides are not coming.
I wish that the people who implement BharatNet, to providing internet connectivity to all Gram Panchayat, they notice that in Palghar district in Maharashtra, tribal villages don't have the connectivity, and it is a very important issue. And then he also talked about that the current healthcare situation. Yeah, please carry on, Dr. Suresh.
Yeah. So Manish, please help me go to that slide.
Sir, I am uploading your PPT. You just Till next, I'll go on the
I,
next.
yeah, he will make it from his one. You just to say next.
Yeah, that is better, I think.
He will, Mr. Manish. You just to say next. Then you will do that.
Okay. That is better. Now,
Now you can put
see
video
now, Manish.
on. Dr. Sureshji, you can put your video on.
Yeah. Now, next.
So he is getting connected, and he talks about the empowerment, self-reliance, and health data collection. And he says that it is necessary to go for the full, full community participation in planning, accountability, and its highest priority. Use of enabling technologies and digitalization of tribal health data. And this is an important thing. And he also talks about delegation of medical roles and skills to community and leader development
Yes.
and massive
Yeah.
efforts.
Next.
Yes, yeah, I, I'm giving some connectivity. Yeah, okay. Please speak.
So this three pillars. Should I stop the video? Video. I
He
told
will
you.
do that.
We have three pillars. Huh? One is active participation. Second is use of digital tools and self-reliance. The active participation through selection and training of healthcare workers. What is this healthcare workers? We select the couple which is newly married and studied up to say 10 or 12th standard. So we train them in storage of data and digitalize lock. Then use of the most accurate digital diagnostic tools. Like our instruments that we use for measuring
So active community participation and that selection and training of healthcare couples for collection and storage of health data in digitalized health lockage and use of digital tools or for use of more accurate digital diagnostic tools for early and in advance detection of non-communicable diseases and also facilitate teleconsultation and referral to secondary and tertiary care hospitals for further treatment for the patients detected with the disease from red and yellow alert zones. Yes, from that point onwards.
Yeah,
Dr.
next,
Sri.
next slide. Next slide, please. Manish. Manish, can you go ahead? Action plan is of this Atmanirbhar project. Next. So we live in three health zones based on our unmet health needs. Like where the whole health needs have been met, that is green health zone. Where partial unmet health needs, that is yellow health zone. And where there is a complete absence of unmet health needs, that is red zone. Next. So what are these health zones? So first is a green health zone. Living in a green health zone, looking after self-health. So we are conscious about the health, enjoying good health and well-being. However, if neglected, we can be pushed to yellow healthcare zone and subsequently to red health zone. So that is what happening. We are born and brought up with very good Indian culture, having balanced diet. But the entry of this fast food is pushing us to the other, that is yellow alert or red alert zone. The second is living in a yellow health zone, living in a poor health indicators like poor health literacy, poor economy, unhealthy lifestyle, and food habits, and living in a compromised health situations, prone to ill health. All these issues, if not attended in advance properly, like the children are studied their hemoglobin is low, they are anemic. So during that age, if you tackle these problems, then all these issues can be attended in advance and properly and effectively, so that effectively will push into they will not, if it is not attended, otherwise they will go to the red health zone. Now, what is red health zone? Living in with comorbidities, having already diabetes, hypertension, accumulated either due to genetic defects like sickle cell anemia, or due to living in all compromised health situation prone to hillia. So these are the already, you can say, adult population which is having these problems, and they are living in radar. Next. So there is interconnection in these health zones and health. So green, if it is not properly treated, it will switch on to the push to the yellow health zone. And if it is not properly taken care in advance, it will lead to the red health zone. Next. So how to do damage control? So we have to control the damage and prioritize the health issues. How and where to capture the early signs of ill health and arrest the further damage in health. So you have to find it in advance, and how to identify target zones and set priorities and focus on those set targets. So we have to decide the priorities and depending upon these three health zones. Next. So like we can see that those people who are living in population and enjoying healthy life as all their health needs are met. Red alert zone, this is the population which is already suffering from diseases because of the unmet health needs. They remain in red health zone by three reasons. Firstly, their health illiteracy is zero. Their health literacy is zero. So they are unaware of their unmet health needs. They don't know even that they are actually what are their health needs. And even the health problems they are like tobacco, they don't know what the tobacco and alcohol causes harm to them, but they go on this. Secondly, their poverty prevents them the access to the healthcare services because they can't go to the private doctors because a lot of money, and public hospitals are not accessible to them. Thirdly, the failure of public healthcare services to reach them, they are just suffering from health problems because mainly health literacy and lack of health literacy and economic handicap. So both, as we have seen, that the poor economy and poor health literacy is leading to live their life in red alert zone. Now, what about this yellow? This is a young population or generation of tribal population comprising of the children and adolescents, boys up to the age of 12. And this is our future generation. They are already having their way of unhealthy life and all burden health needs. So they are following their parents, which are not unhealthy lifestyles. They are already living in a compromised health situation. However, this should be the main target population. So what we have to target is this yellow. Now what I see is that all adult populations already into the damaged health, we can do very little about them. We will do it, but we have to concentrate on this yellow alert zone, young populations. That is our future generation. So if we can concentrate then, and we can in advance train them, and now we can make them alert and can be made aware of their situation in which they are living, which would definitely help them in advance to avoid their journey already destined to unhealthy life. So this is very important. Next. So here we have to concentrate on yellow. So based on these observations, our model is developed as follows. The priorities for red alert health zones will be mainly adult population, early and in advance detection of health problems, and timely corrective interventions for this population is needed. So what we do is that our couples go find out their health problems, what are the comorbidities they are living with, what is the blood pressure if already having, or they can find out through our instruments that for the first time in advance. So and then they should be connected with the public health sector or private health sector. So yellow alert health zone, this is our future generation consisting of children and boys. This will be should our main target population and social health literacy efforts to prevent, control, and advance. So that awareness in detail. Next, please, Manish.
Dr. Suresh, your voice is not coming. Mr. Manish?
So disconnected, sir.
Yeah. Voice, he said next. So, according to the project, that the target is to cover maximum population living in red alert and yellow alert health zones. The project is divided and carried out in following 4 subheads: red alert health zones, yellow alert health zones, providing referral facilities for tertiary health care, and 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 self-reliant village health insurance scheme. Under the red alert health zone, health mapping of a village has been undertaken for early detection and to access the current health situation, and through which the family health card is prepared, and also preparation of health map of a village by healthcare couples have also been undertaken. Yellow alert health zone, this is for monitoring
Added that
growth
in
of
the
children
maximum
who
population
are health
living
grade
in
cards. Yes.
cover the maximum population
Yeah.
living in red and yellow alert. The community therefore divided into for the population living in the red alert zone. We do health tracking of the village for early detection of these populations. On that basis, we prepare a family health card by the different efforts to their diagnosis of blood pressure, hypertension, blood glucose, hemoglobin, BMI, and from that we prepare their family health card and a preparation of health map. In case of health, we monitor. In case of children in 5 to 12, we call it as star health grade cards and special health literacy and leadership for the development of adolescents. Then third is providing referral facilities. Now, once you know that there are people living with comorbidities and some of them we have already pointed out through our early detection methods, then we need to provide them referral facilities. So that we do it through referring them to the JJ hospitals, because I was working there. So most of the people they know and they give very good treatment. And one of the private is Vedanta Hospital. The last one is self-reliant village, that we are trying to develop a model where a village level health insurance scheme will be discussed. Next. Next.
It is already there. Healthcare couple was there, which, hello?
So now this is our existing robust network of 30 healthcare couples working in 30 villages. Now you can see that these women, they are carrying their kids with them. Some of them, they even came when they are pregnant up to 9 months. So this is amazing, really, their community participation. So, so that is I just wanted to make a point over here. Next. Now you can play this video. We provide them appearance, attendance card, labels, and a board on their food. That gives them identity at the village level. And we are documenting. So we are trying to replace the public health care system by this. We have then opportunity for their this is really, and this idea of giving their boards and all, it's really working very well. So now rapid risk development through the use of digital health diagnostics. Now here what we use that the regular and digital screening tools are devised and risk is calculated on the basis of following 4 non-invasive risk parameters like nutritional status. We do their BMI, body mass index, by calculating from height and weight. Then if suppose the BMI is low, that means they are suffering from anemia and wasting and stenting. Then if it is more, then they are usually suffering from comorbidities like blood pressure, blood glucose. Then second is the rapid digital blood check for anemia, heart problems, diabetes, blood pressure. And even we have got one AI-based, artificial intelligence-based stethoscope developed by one of the Bangalore firm. So that can easily point out the heart problems, just putting the stethoscope on the heart and you can find it there. So that is also being used. Now, this gives the health history on physical and mental disability, cancer, kidney disease. These are the other parameters we are including. Because the addiction of tobacco and alcohol, the community will not tell that I am a tobacco or alcohol addict. But because we have got this community-based couple, so they know who are the tobacco addicts. We don't need to ask. So they can easily find out these people are tobacco addictions and these are alcohol addictions. So that data is immediately available. That will not be available for us. If you and me go and ask, they will never tell this. So this is another advantage of community participation. Then measurement of purity of drinking water. So we have found that the drinking water they are using is not pure. So what we do is that by find it out the total TDS, we have given a simple instrument to measure the total dissolved solids. And also we have trained them to use the alum. So what they do is that they use alum and just put it into the say bucket of water and rotate it in the water for 1 minute. So all the solid materials will settle down. So the upper material or water, they will check it and they will boil it and use for this. So by this simple method, so they can get a drinking water of good quality. So we have provided them with alum and total dissolved solids. Now we'll ask why total dissolved, because there are a lot of kidney stones cases. That may be because of the solid contents are more. So that again we are taking care. Next. So here you can see we prepare 2 types of village graphs. So in a particular village, you can see all the graphs, homes are there numbered. The first graph will give the general conditions. Like here, it will mention T if the toilet is there, G if the gas connection is there. So you can find out on this how many homes they have toilet and gas, how many they have toilets, how many they have gas. So by this, you get a general conditions and even what are the sources of water they use, and also how they the overall structure of the village. So this we display into the Samaj Mandir, what we call it is that. So they prepare this and display. Next is the health chart. Next. That is the health map of the. Here you can see, here we put the simple bindiya, what the ladies use for now. So on these homes, like red bindiya on that particular home means a patient of anemia. Then this brown means patient of blood pressure. Like that, you can find out where are those homes where both blood pressure and all those. So this is again displayed into the Samaj Mandir. So even the district health officer or taluka health officer come, he can get easy information, and they can arrange their medical plans accordingly. All specifically to these people who are already next. So this is mapping for their diseases and vaccination. Even we do find out how many of them are corona vaccinated. Second, first dose is they have done, but second dose none of them have done. So that is also a finding we have done through this. So the first is general condition of the that is health condition of the particular village, and this is very good, you can say, tool for monitoring, even for a district health officer or the local health officer. So you can easily monitor which are the non-communicable diseases prevalent in which area. And if it all our problem, our idea is we are going to digitalize. So then you can find out the clusters. So in Palghar districts, which are the clusters where blood pressure is more? Which are the clusters where anemia is more? To digitalize this map, so that you can easily find out which are the clusters which are prone maximum to.
It's talking about the health map, mapping and marking of all homes for diseases and vaccinations. And today you have a lot of technology tools available like GIS tools. And with that digitalization and application of GIS tools will bring out this health map is easily, you know, developed, and also health informatics can be displayed over there. Please wait, he'll be joining now, and there is a lot of internet connectivity issues. It's very important. Please wait. Mr. Manish, you can go to the next slide. Yeah, the map, you can display these maps.
So a lot of problems are coming up. Internet. So for children. So these are the projects we are doing. First, for the providing health and health literacy to the population in yellow zone. First is Star Health Grade of Children in the group of 5 to 12. So what is it? Just let us know. You know, students are given grades as per their performance in mathematics or other sports and everything. They are given grades like stars. Nowadays, there is a fashion of giving stars: 1 star, 2 star, 3 star. So now we have developed this for health. So here, what we do is that we are giving the health grades. Like say, a person, a child which is having. Next slide, please. 4 parameters usually we check. Like this project is aimed of detection and prevention of control of stunting, wasting, and anemia in children, which is in this area 90%. Though this project, through this project, the teachers, children visiting our Madhav Sanskar Kendra, these are our, you can say, small Sanskar Kendra, which we do it at the village level, where these children come and their parents are educated on how to monitor the growth. The growth of children is monitored through, as I told you, 4 health growth indicators, namely height, weight, BMI, and blood hemoglobin, and called as star health grades. 1 star is given to each parameter, like health, height, weight, hemoglobin, and BMI. Based on these measurements, every child is awarded star grades. The child who has the normal height, weight, BMI, hemoglobin gets 4 stars. So he's totally normal. His height is normal, his weight is normal, his BMI is normal, hemoglobin. So he gets 4 stars. And the rest children gets 3-star grades based on their score and mathematics. The children who do not earn 4-star grades indicates that they are underweight, underheight, and have low hemoglobin, hence blood get wasted and are anemic also. Next, please. So this project, through this project also, we have found that the community participation is very good. The parents ask, why my child is getting 1-star or 2-star, why not 2-star, 4-star like the other child? So then the questions come from them. Then we educate them because you are not giving proper diet. So that's the problem. Next, please. Yeah, now you can see here. Now this one boy, which is having 4-star, and rest are all stunted and underweight, underheight. But when we compare this boy and tell the parents that, see, your child should be like this and not this. So that gives a tremendous effect on their, you can say. And this is really working very now. This actually project I started first in Varanasi. And it is working very nicely. Next. So we, after coming to the Palghar, we did a study where what we did is that the initial baseline status of star grades found out were 1,000 students in around 30 villages, and they were given star health at that particular time. The data revealed that 95% of the children are malnourished. So this is the baseline data, and 60% are anemic. Based on these findings, the treatment was planned and was carried out in 2 groups. We made 2 groups of villages. In 10 group, the treatment group A of 10 villages, the children who were found malnourished and anemic from these 10 villages were given treatment with nourish laddus. We prepare some laddus and which are having all those, you can say, dry fruits, then dates and everything. And those were given together with anti-worm. Once in a month, anti-worm albendazole should be given because that is the main what we call worms. They call anemia. So the first anti-worm 1 tablet is given, and then iron folic acid tablets are given. So this is a group of 10 villages where the nutritional laddus along with the iron folic acid is given. Now the control, the other group B, another 10 villages where only anti-worm and iron folic acid tablets given. Nutritional laddus were not given to them. So in both groups, the treatment was given for 2 months. So in one group of 10 villages, the laddus with iron folic acid for 2 months, and other group 10 villages, the treatment with only iron folic acid. So that we wanted to find out because that is the scheme of governments. If anemia, give the iron folic acid. Next. So our findings are really, you can say, amazing. Now we find that the impact of treatment in 2 groups. Now the first group where the normal height was reached from 4 to 27 students. Normal weight was reached from 5 to 13. Normal BMI is reached from 128 to 167. That is after feeding with laddus and IFA tablet. Normal hemoglobin was also doubled, having all 4 stars. Initially, there were all students were no, not a single student was having 4 star, but it has increased to 7. And total stars were also increased from 260 to 2. But if you look at the other, where only iron folic acid was given, you will find that the normal height was not much, weight was also not much increased. Normal BMI, on the contrary, it was reduced. The normal hemoglobin also reduced. And having 4 star also was not significant. Only 1, it has gone to the 4. Even in case of this total stars also, here you will find that 415 stars were increased, whereas it is only 330. Now, what is the meaning of this? Let's see. Next. See, in a total group A, treatment with laddus and IFA was given in 279. The increase in the total number of stars was 279 students. So that is a 57% increase into the total number of staff. Increase in the normalizing level also 160. Why so? Because protein supplementation favored globin production and IFA favored the hemoglobin. Now you know that heme is a hemoglobin. So it needs heme iron as well as globin. Globin is a protein. If you in second group we provided only iron folic acid, so globin was not provided. So the results were not significant. So all our national programs are concentrated on giving iron folic acid, iron folic acid. But unless you give the globin in forms of nutrition, then you are not going to achieve. So this is the very important findings we got from this, that the children need to be given iron folic acid with nutritional diet. Then only you will get rid of this stunting, anemia, and all those things. Next, so this is very important finding. Now what we did is that after we stopped complete treatment in these villages for 6 months, and again checked in both groups, that in 10 villages, in especially in where the laddus were given, when the nutritional supplement was given, and 6 months nothing was given. So we find that they again reduced to 12%. So that means supplementation with protein need to be continued. So this is another finding. Next. So how to overcome these problems? We need to refocus our objectives. All national programs for treatment of anemia should be supplemented with nutritious diet along with the treatment of iron folic acid. Only iron folic acid is not going to work. Vigorous preschool education and awareness of teachers and students on importance of nutritious and balanced diet is very important. Emphasis on educating parents to improve awareness on good feeding practices. How to cook nutritious food in low budget, training on growing up all possible vegetables and fruits through kitchen garden. Here the agriculture people will be of great help. So we need to develop kitchen garden where all the proteins will be provided in this kitchen garden so that they don't have to go outside. So that is very important. And education on better overall health and sanitation. Sanitation is also important because worms are the main cause for anemia. Next. So we need to refocus on these objectives, especially for now. Come to the adolescents, boys and girls. What we do is that health literacy through special task of basic data collection on unmet needs of a village. What we do is that we train them to collect the basic data. What is the advantage of this? They go home to home and collect this data, and they come to know that, see, our village, this thing is not available, toilets are not available, gas is not available. Otherwise, they are not aware. But when they go on baseline data, they get aware of all these things. So that is the idea, that basic data collection for unmet needs. And secondly, we need to have a leadership development, because we need to have a leader from the tribal village only. Now what happens? All the leaders are coming from outside and they are least interested. So we need to develop the leadership program for these young boys and girls, especially girls. So there is special education, awareness and training to the adolescent boys. What we do is that 5 adolescent girls and 5 adolescent boys are selected for 20 homes in each village. So each village, what we do is that 5 girls and 5 boys are selected. Two groups of them are formed in each village, namely Savitri Bai Phule. This is just to encourage them because she was the lady who did the education program, and Vivekananda Shakti Kendra for boys. So these two groups are formed. Now, baseline data collections on unmet needs. Which are those? Housing conditions, where the house is kacha or pakka, overall education and employment, how many are employed, what is the education status, how much are their graduates, how much are the postgraduates, and how much their employment potential. Then availability of basic facilities, like where there is a primary school, primary health center, provision of clean drinking water, pipelines are there, toilets are there, closed bathrooms are there, wastewater treatment is there, use of wheel grass, etc. So I have prepared one baseline structure. So they go home to home. The idea behind that, pushing these adolescent girls and boys, is that they get aware of where do we stand, where do our community stands. So automatically, my idea is that they will be uh, means do something, and they will feel that we should do something. Then secondly, detailed action plan is designed to provide. So then we take a meeting with the Gram Sabha, and then a plan is organized so as to come out of this unmet health needs. Next. So now there is a leadership and skill development. As I told you, leadership has to be from the community itself. Even say 5 villages of tribal, one leader has to be from there. And young boys and girls, even girls are very important. And girls, as I have seen their community participation is very good. So empowerment through the various leadership and social awareness program, we do then the training. Employment potential is being improved because they are now just done their 12th. So we need to train them, like we are trying to start a nursing school or ward-wise schools or the other faculties, so that they can get an employment for the 12th standard. Because in this area, there is a tremendous need, and this is a where the lot of manpower is needed, not only in India, outside India also, because where these healthcare workers are in very much demand. So that healthcare workers in form of training, and this is very important. Now, health literacy, what we do is that I have found that these video clips are there, which we show them. These are animated, and we show them like ill effects of marriage before puberty, pregnancy before puberty, gender inequality, on menstrual hygiene of girls. And for boys, ill effects of tobacco, alcohol addiction, violation of road traffic accident rules, and gender inequality. So first of all, we show them these videos separately, boys and girls. But then afterwards, we call them together and show them, and then we have a discussion. Because most of the boys, they don't know the problems of the women or girls, how they face to the menstrual hygiene. And they have to know that what is this menstrual hygiene. And they are not aware of this, so that they will be more, there will be gender equality. So they will be more considerate to their wives and girls. So that is the idea. Because I have seen that when I showed this videos on menstrual hygiene in a group. So the first thing, the boys comes that sir, we didn't know all these things. We need to know all these things. So that is very important to show all these problems of women, gender equality and menstrual hygiene, early marriages and pregnancies, multiple pregnancies. So these boys also should know. And I have seen that the most of the boys here, there, they have got bikes, but don't use helmets. And I am really unfortunate, or you can say very sorry to inform you that one of our couple, boy, from this, the boy died because simply he didn't use the helmet. So he met an accident and he died on the spot. So this is very important, that how important it is to the road traffic rules and gender equality. Next. Now, the provision of primary, secondary, and tertiary healthcare facilities. Now, once we find out that these are the problems and these are the people they are suffering. So, what we have to do is that comprehensive primary healthcare education on preventive, promotive, curative, and rehabilitative through outreach by our healthcare couples. So, we train them on importance of sanitation and hygiene, importance of all these problems of menstruation hygiene. So all health literacy is given them. So that will help them for preventive and promotive, curative, rehabilitative stage. Second is, we have, as I told you, collaboration with the Palghar district health authorities. They help us for the provision of medicines in case of primary care. The district health authority provides all the medicines, most of the, especially anemia, they have a lot of stocks, so they will dump at our village, use it. But this other this NCDs, they don't have most of the time the stocks. The third is referring the patients. Now, once you know that the patient has been identified in advance, like one of the child who was having juvenile diabetes, and he was remained untreated since last so many years. So we referred it to the JJ hospitals with my acquaintance. He was admitted there. He got cured. Now he's taking insulin regularly. So like this, again, this is very important to get their confidence, because they get that. See, we get a complete treatment. We get a complete, I say, the complete solution is very important. Now, most of the people, what do is that they do the camps and just see that your diabetes, your hypertension, and medicines are not provided, because these people don't have money to buy the medicines. So what is the use of taking medical camps over there unless you have a provision for providing medicines for them? So that is what we are doing, either referring to the secondary and tertiary care. And the other project that I will discuss afterwards, there's a possibility of, because I told you that there are cancers of breast cancer, uterine cancer coming up, kidney diseases are. So we are now thinking to explore the possibility of having daycare centers at our hospitals. So we'll call the oncologist once in a month, and then we'll provide them these facilities. So this is next. So now, what is self-reliant village health insurance scheme? I told you that there is a problem. They don't have money, poor economy. So even if they know that they are diabetes, they are hypertensive, all, but where is the money to buy the medicines? So what we need to do is that. So that is what we do is that. This is, we recently introduced village health insurance scheme. Next, what we do here is that we collect the minor amount from the each and every home. Because the participations is very important. So next slide, please. So, sorry. No. This has gone backwards. This has gone to the backward slides, maybe some 10th or 15th. Yeah, next. So here what we do is that, as I told you, indebtedness, rampant poverty and deficit economy, loss of tribal rights or land forests. So main problems is financial handicap. So they don't have these adherence to the panchayat decisions, lead to the land alienation, because they were the forest. Now, as I told you, they don't have land on their name, so they cannot avail the government facilities also. They are just like a bonded labor act. And lack of education, industrialization, and problems of tribes, and lack of communication. Next. So poverty is the main important thing, especially in case of these raid alert health zones. So here we need to provide them financial assistance. And what we do is that we use two methods: by collecting the small amounts from each and every home, and preparing you can say a kit, like suppose even if 4,000 from 50 homes are collected, and then that will be added with the donations and CSR fund, so that a particular village will have, say, 50,000 rupees at a particular time, so they can get the medicines need can be fulfilled. Here we cannot depend on the government. So participation is very important, because unless you take something from them, that will not be given importance. They will just don't take the medicines, because this, as you can say, everything free is not valued. Next slide, please. So the aim of the subject is that making financially self-reliant village. It is common observation that anything provided free of charge is not valued and hence not used properly. So a small contribution from each and every community member is more effective and useful in long run in community-based program. The village level health insurance scheme is being initiated, where the small contribution from all villagers is collected and used as an insurance fund for the treatment of villagers. As I told you that it will be say 100 rupees per home. So that will not be much more than 5,000 rupees per village. So that is not sufficient. But this basic fund is then supplemented with getting donations and CSR funds. This will provide each village with a kit of sufficient funds to support and satisfy all their unmet health needs, especially provision of medicines. So that is the idea. Next. Now, what are the outcomes and case studies? Now, as you should, there is no records available. Painstaking created records, like we have created records. Our couples go home to home, collected the records they have done in the Parivar Swasthya card, family health card they have prepared. That is a hard copy, but that can be lost. So, painstaking created records will be lost. So, what is the use? So, we thought of digitalization. Next day. Yeah. So here what we do is that launching of a QR code based wearable health locket. This is we did in collaborations with the private firm Brand Care, which are having this software done for us. Next. So this is digitalized health locket project. It is an endeavor. Recently we have introduced this. We have developed the wearable locket embedded with QR code. So you can see the QR code in the locket, which is linked to the digital data of the family health card collected by our existing robust network of healthcare. So these couples, they collect the data working in 31 village, and that is linked to the QR code. Now this record will be available and accessible all the time and in emergency situations also. Next. So you can see this is a simple wearable Swasthya locket, which will be following main advantage. Being wearable, it will be always available. QR code will allow all family health records to be available and accessible in emergency situations. Records will be permanent, will be updated every 6 months, and can be recovered easily and used whenever needed. Simply by scanning the QR code, these family health records will be available to the treating physicians during the next visits to his clinics. Also, in case of accidents, if the person is wearing the locket, there is phone number is there, their home address is there. So the police can easily find out. In case of child missing, trafficking also, it will help the police to trace and locate the home of a person. In case of loss of locket, when informed immediately by the user, we will immediately block the system. Next. So these are the main advantage of this Swasthya locket. So what are the, this will allow us three broad improvements. First, health record access, shortening the time to treatment and reduction the diagnosis cost burden. So now every time they have to do blood glucose, blood sugar. So now already data is there. So that will shorten the time of treatment because already they have been diagnosed as hypertension, blood pressure, anemia. Diabetes and anemia. So this will shorten the time of treatment. Immediately the doctor was just scanning the QR code will find out the patient person is suffering from hypertension, anemia, or diabetes. So immediately treatment can be started. This will reduce the diagnostic cost burden also. Otherwise, what will healthcare person will do? He will again write the test, do this blood glucose, blood anemia, or blood hemoglobin. So that will again cost reduction. Then prevention and treatment. This will enable us to build prevalence clusters of both communicable and non-communicable diseases. That I told you that we have. This is our future project. That wherein we'll find out the clusters where this particular part of Palghar district is more prone to diabetes. This particular is hypertension, like that, and this particular is anemia. So then we can concentrate on that area. Then improvement in quality of life through the education about drinking water, sanitation, and cooking gas practices that I already told you. Why cooking gas is required? Because of the fuel problems, they get a respiratory tract infection. Sanitation is important. Drinking water purification is important. So the quality of life will be improved. Next. Here, because they record all this. So digitalized wearable health record will allow immediate following broad improvements, easy health record access, shortening the time to treatment, reduction of the repetition of diagnostic cost burden, early detection of disease, avoiding future complications and emergency. Next. So now this is the case study. This boy, age 14, diagnosed with type 1 diabetes, but not taking treatment. No medical files are available, no record of treatment, and he is not taking treatment itself. As I told you, last week only we referred it to the JJ hospital. Now he's okay. Next. So for this, there was no record. We for the first time find out that he is a diabetes. This is another person, Anand Palvi, age 55, diagnosed with hypertension and diabetes, but no records. No records of treatment of history. This Tarawak, 60, needs regular treatment. Ananta Gaikwad, age 55, is a brick clean worker, maybe suffering from respiratory, but no medical records. No records of treatment history. Next. So, in all such cases, availability of quick access to the health record to a physician will reduce time of diagnosis, cost of the diagnostic test, and improve overall outcomes. Health Locket is a unique approach to making health history available to the physician when physical health records are destroyed, lost, or not maintained. The data can be used for analyzing disease trends and prognosis in the cluster. The broad outcomes will include reduction in the time to diagnosis, reduction in the cost of diagnosis, and continuity of medical treatment. Next. So this is the health locket. You can see it is very beautiful. They liked it and they love to wear it. Next. So preliminary findings after digitalization of the services are this. Now, in case of the first slide, please. We got the record of 2062 from 25 villages out of 30. The total number of checked by healthcare couples, adult males was 934, adult women 11,040. The early detection in adults revealed that 62% are male. They don't know what they suffer, and 70% female are suffering from health disorders, but they are not aware of this. Any of these. Now, what are those? Next. So now anemia is in case of 24% of the male, we find out that they are already anemic. Hypertension, in case of 3% of the people, they are already hypertensive. Diabetes, 4%. They are 26% underweight. Overweight is 7%. And overall early detection is the 62%. In case of 62%, we found out all these parameters. So now they have got these data on their health conditions. Next, this is in case of males. In female it is more. 71% of the female they have been detected, out of which 35% is anemic, hypertension is 2%, diabetes is 2%, underweight is 26%, overweight is 6%, and overall detection is 71%. So with the help of this digital, we can immediately and very effectively could find out that they are suffering from all these diseases which they are not aware of. Next. So what are our future plans? Our Health Locket program will allow quick access to the healthcare providers in 31 villages, covering nearly 2,000 households at 11,000 people. Now, as I told you, we have presently covered 2,000 population. We'd scale it up and expand it further to 10,000 more households over the year, allowing the reduction in the time and cost of the treatment to these. Because of the scaling up, the cost will automatically reduced. Next. So we got a recognition from the national project, like national presented this international organizations like United Nations, SDGs at Chitrakoot in 2012. This year also. Then national level NGO, DRI, that is Deen Dayal Research Institute. They have actually developed this Dampatya concept, couple, but they were not able to do this properly. So they called us. Because Nanaji Deshmukh has developed this Swasthya Rakshak Dampati. But their problem I saw is that they have selected from outside the community, outside the village. So that is not taking problems. Like we have covered 30 villages, they are not able to cover even 10 villages after 30 years of services. They give higher salaries, even 10,000 rupees salary is given. All those are from graduates and all, but their program. So they specially called us to train their these couples. Then national international organization second. This year also I presented this digital African Asian Rural Development Organization. Like last month we developed. Now Tata Institute of Social Science is also considering our health project for their further studies. And now Professor Moni has also expressed, the National Technical University, that Meerut has also shown interest. Next. So we are getting a very good recognition for this project. So how our healthcare programs can be helped to control incidence of NCDs? Sharing of experience and knowledge in following two areas: health mapping of the village by preparation of family health card, preparation of health map of the village by trained healthcare workers. Then star health grading of the children. And third, application of the digitalized health locket program, which will allow quick access. And the health locket project is cost effective and can easily be duplicated. Next. So these are some milestones that we started in 2012, the star health grade. Then health couples we started in December 2012. In January 2012, we come up with the adolescent girls and underage mothers. In July 2020, Parivar Swasthya Card and Gram Swasthya Nakasha were projected. Next. So these are some of the milestones. Last year, we developed this referral system to JJ Hospital. Then third checkup of the MSK students, where we found out that the nutritional support is very important. Then introduction of Vivekananda Shakti Kendra and the Savitribai Phule Shakti Kendra for girls, adolescents to leadership development, and launching of digitalized healthcare. We launched this digitalized healthcare with the help of Brand Care on the 7th of January itself. Next. So these are some of the future plans, like village health insurance scheme, as I told you. Then May, June, we'll start with introduction of daycare center for cancer and kidney diseases. June, July 23 will for a provision of mobile vehicles or patient transfer to JJ Hospital. August, December, we'll study the impact of digitalized locket. Next. So the project is in a collaboration with Keshav Srishti, Brand Care and District Health Services of Palghar. The project has so far successfully succeeded in collating each information hidden in the various databases or studies, analyzing and interpreting it, and constructing the comprehensive picture of tribal health and their healthcare through the active community participation, like in health mapping of the village, star health grade, the idea of digitalization, and also the adolescent leadership development from the adolescents. So we'll be happy to train and impart knowledge to any other organization waiting to this run this. Next. So this is a small video.
And serenaded by blue skies and blue waters. This little village in Western India is typically what most villages in this belt look like. Camouflaged by soft surroundings are these hard-working tribes. Fields, fishing, brick kilns and manual labor provide them their livelihoods. They are happy in their lives until they are not. They are unaware of what affects them. So are their healthcare providers. If only the healthcare provider had known that she is highly anemic, he would have known what to do.
But there exist no health records, not even the basic. Their records are as empty as their houses. No one maintains even the basic record of their health that can be used at primary care. They fear going to clinics because examination and diagnostic tests cost more than their earnings. Local medicine or local medicine men it is then. People land up in emergencies because simple information about their anemia or diabetes or hypertension is not recorded and not handy. Keshav Shrushti, an NGO with a health agenda, has been implementing its Gram Swasthya Yojana, rural health development. Keshav Shrushti's Swasthya Dampatya health volunteer couple collect health information from individual households. Their challenge is families don't keep them and painstakingly collected records are lost. Digitization was needed. Brand Care created a simple digitized version by creating the Keshav Shrishti Gram Swasthya Yojana software that captures every family's history into a unique QR code. The program can run even in cases of connectivity problems. Once generated, the QR code is printed and sits firmly, well protected in a locket designed with local tribal art sensibilities. The family head or spouse wears it with pride. The primary care physician finds it simple to use. Basic medical history is now quickly available. This medical visit just saved Asha a few thousands in blood tests. Dr. Suresh knows that her fainting spells can be because of a low iron. Asha's confidence in medical care has gone up. Swasthya Locket was inaugurated in this village by the village head. The Keshav Shrushti head spoke about its importance.
ग्राम स्वास्थ्य हा प्रोजेक्ट त्याचं काम दाम्पत्यांच्या थ्रू चांगल्या प्रकारे चालू आहे. त्याच्यामध्ये स्वास्थ्य लॉकेट आणि डिजिटलायझेशन ऑफ दी परिवार कार्ड हे काम सुरू केलेलं आहे आणि त्याच्यामुळे नक्कीच खूप चांगला फायदा होणार आहे. आणि ह्या कामामध्ये आम्हाला ब्रँड केअर या कंपनीचं खूप मोठं कोऑपरेशन होते, त्याबद्दल त्यांचे धन्यवाद.
आपल्याकडे अत्याधुनिक लॉकेटचं पदार्पण होत आहे. आपण जो विचार केला आहे तो विचार आणि त्यांची जी संकल्पना आहे ती संकल्पना खरोखरच अतुलनीय आहे.
The health locket blends with their lives, their surroundings, their culture, but stands out as a unique initiative to keep health records handy. Call it an ornament, a record, a QR code, or simply an idea that can change lives.
Next, please. Yeah. Now that last slide, additional scaling up, that I have to put it now. Where do I go? From directly, I take it from my laptop.
Sir, I am putting, sir.
Manish, that last slide of scaling up.
Sir, I am putting, sir. I am putting.
Yeah, please.
Video on.
Sorry?
Dr. Suresh ji. Okay, good.
So how can you scale up this project in other villages? That was the question. Professor Moni, I prepared this slide. So usually a time period for implementation in 5 villages with a population of 200 inhabitants is around 6 months. There are different cost heads like human resources, like cost of the data collection, cost of training of head of the project, like director, cost of training of supervisor, cost of education of healthcare workers, and the other staff. Then cost of software deployment and services, data entry, data security, auditing. Then cost of materials, like cost of digital diagnostic instrument. This kit we are giving, it is costing 50,000. Even simple machine like glucose, you get it the Chinese machine, Chinese made machine at 500 rupees in the market. But our glucose machine is costing 20,000 rupees. So the kit gives accurate results. So my idea is that the results should be accurate, so nobody should challenge it. Otherwise, the whole efforts will be wasted. So this kit cost me around 50,000 rupees. Like they have got all these instruments. Then the approximate budget for implementation in 5 villages with 200 inhabitants will be rupees 10 lakhs. That is 2 lakhs per village. That will include also this treatment cost in case of the detected early detected diseases. So that's all, sir.
Okay,
Thank you.
thank you very much. Thank you very much. And you can come out from the presentation mode.
Yeah.
Thank you very much, Dr. Suresh Saravdekarji. It is a very important presentation. And even though we had intermittent disruption from internet, you are addressing
Yeah,
from a remote village, tribal village, not only remote
yeah.
village, but it's a tribal village.
Tribal village.
And but still you made it. That's why we
Hmm.
made it to, we had to make some arrangements that,
Hmm.
presentation from studio, and, your video was made to, made it to,
Hmm. Yeah.
was off, and only voice communication was made available. So the last leg of the program was not disturbed. But
Yeah,
this
yeah.
is the condition. You would like to bring in technology to the rural area,
Hmm.
until unless people like you go down to the grassroots level and experiment and communicate to the world that this is the situation which we are facing it,
I see.
how the policymakers will come to know about it.
Yeah.
So in that way, this is a very important, webinar which the Soviet Institute of Engineering Technology, deemed to be University Meerut, has conducted. That it is an eye opener,
Thank
and
you, sir.
we would like to see that at the grassroots level, that is, we have to ensure optimal nutrition in the soil,
Yeah.
and harvested food to
Hmm.
ensure to minimize human disease.
Right.
That's how the Dr. Ashok Dalwai Committee report on doubling farmers' income by 2022. The report was submitted in 2018 on digital technology in agriculture. The committee talks about integrated farm health management system, and that it talks about human health, plant health, animal health, soil health, water health, fish health, and environmental health.
Hmm.
So this, I'm very happy that you have undertaken this project in 30 villages.
Yeah.
In with respect to, the data, of that about the people from the 30 villages with respect to human health point of view. But with your same team, which you have got a well established team, if also under the smart tribal farming, and also that smart tribal village, and we also try to see this integrated, the health informatics program, health informatics network value chain. Health informatics here, what we consider is that human health, plant health, animal health, soil health, water health, fish health, and environmental health. And this is very important because the minerals of the soil controls the metabolism of the cells of human, plant, and animal. You as a doctor, you know very well that.
Yeah.
So I would like to request you, in this component of the Dr. Ashok Dalwai committee report, if we
Hmm.
also try to see, you have done a lot of work with respect to the human health component.
Hmm.
And if you also have other components, then it will be a very good, pilot project to be replicated. And also it will also hold that in the operationalization of the doubling farmers income by committee report, which was set up on the direction of our honorable prime minister Shri Narendra Modi in 2016. And these recommendations have to be operationalized. That's why this university, during the COVID situation, this initiative was undertaken, and today is the 110th edition of this national webinar series on doubling farmers' income by 2022. And we have had another webinar series on international webinar series in association with the African Asian Rural Development on open source digital technology towards self-reliant India. So what are the technologies which India, develops should get, it will, the technology transfer can take place through ORDO organization to the, member countries, its member countries, 16 African countries and 15 Asian countries and one associate member country. So I'm very happy, Dr. Suresh Sarvadekarji, for your wonderful presentation, a practical presentation, and a grassroots level operationalized project. I was moved by the videos which you have shown, the ground condition, and also that with the data which you have presented, and researchers data with the ground level data. It is not based on secondary data, and it gives a lot of understanding, and also that it is very important that such type of ground level project should find a way in the policy making for policy formulation. And it's very important, and I'm also very happy that you have given how this project can be scaled up. For your information, in order to operationalize some of the recommendations of the Dr. Ashok Dalwai Committee Report 2018 in the volume 12B, Digital Technology in Agriculture, where I was closely associated as the group leader, that we have to operationalize the digital technology in agriculture in 3 categories: smart irrigated farming, smart tribal farming, and smart rainfed farming. So under the smart tribal farming, 7 categories, and the 7 categories are: one is that integrated health informatics. And it is a $1 trillion data economy with the adoption of artificial intelligence, big data analytics, and blockchain technology. And we can bring in lot of students with some biology background by training them on artificial intelligence and data analytics and blockchain technology, and also data analytical capability with respect to health, human health, plant health, animal health, soil health, and water health, and fish health, and environmental health. This will be an important value chain for bringing in, this holistic health at the grassroots level. And in the data analysis alone is a $1 trillion data economy. I visualize India to have a data center with the 10,000 data scientists on the health data analysis alone. We have India is a rich country in its own Indian medicine. And this also has to be looked into it. Not only human health has got various, protocol for health aspect. Allopathy. Today, allopathy, most of the, that their practices are digitalized. And today you have shown it even at the tribal area, how you are able to make it successful. It is not happening in other places. You said very clearly that even if the government, post doctors in the tribal area, the doctors see to that they see that, it is a punishment posting. And they either go on leave or they come out without any, interest to serve. There are some exceptions. Some people, they didn't want to get posted out after getting into that tribal area. They have a complete, they become like a missionaries. There are exceptional cases. There are a lot of doctors who have been posted, in the tribal area. They, become a missionary in the tribal area. And that's, it's part of the system, but we have to bring an integrated approach, because tribals, they have their own traditional system of medicine, which has to be understood, and allopathy system, Ayurvedic system, Siddha systems, Unani, homeopathy, and we have to digitalize that how each system of medicine, Indian system of medicine, along with the allopathy, is what is the the protocol for disease treatment. And I'm also very happy from reading your profile that you are a man who has a passion for positive promotion for wellness, and not for negative promotion of negative disease promotion. And how many doctors we have in this country, like Dr. Suresh Sarvadekar, and holistic health is very important, and that's why I have been propagating that health informatics network value chain. This is the first university. There are this university is a group of two universities: Shobhit University Gango and Shobhit Institute of Engineering and Technology, deemed to be university, a NAC accredited A grade, deemed to be university. And this is the first engineering technology university to have 5 centers of excellence to promote technology in rural India through 3 areas: agriculture, SMEs, and health. And this is the 3 areas through 5 centers of excellence. We are very happy in this aspect, and we also undertaken a lot of pilot projects in a cluster of 10 tribal village in states from Gujarat, Maharashtra, Madhya Pradesh, Rajasthan, Chhattisgarh, Jharkhand, Odisha, Telangana, Andhra Pradesh, Karnataka, Tamil Nadu, and Kerala. So we'll be very happy in association with Dr. Suresh Sarvadekar to include his project initiative in 30 tribal villages of the Palghar district, in the cluster of 10 tribal villages, in other states, that let us include this project component. And also I would like to request Dr. Suresh Sarvadekar to also to look into other components of that, what we would like to propagate. And this can be included in your existing ongoing experiment, and to bring in soil health component, plant health component, animal health component, and fish health component, and you already included water health, and also that the environmental health. So that will be a very good thing. That will be the first village experiment in the whole world.
Right.
And that should be achieved, and that's why I have been voicing from 2011 onwards, included in the Dr. Ashok Dalwai committee report. I am very happy, and with your support, let us do that. And with this, I would like to have your final remarks, and then I will close the webinar. Over to you.
Thank you, sir. Thank you very much, because for your lots of appreciation. I have a passion for working this, so definitely I will be with you for knowledge and experience sharing. That is my passion. So I like to work with you. So, and thank you for calling me and giving me this opportunity.
We also would like to initiate through the Center for Health Informatics and Computing. I would like to associate you as a core member of that Center for Health Informatics and Computing. The objective of this Center for Health Informatics and Computing is to generate human resources in the area of health informatics.
Yeah, that is very important.
Take a +2 biology students. There we would like to take 50% of the students are girl children.
Yeah.
Teach them artificial intelligence, big data analytics, and blockchain technology and GIS technology, to see this data, analyze the data over a village. You created a health map for a village. That's why I'm saying that GIS technology to be given to the the students who understand health data.
Yeah.
So this is 3-year course on BSc Health Informatics and 1-year diploma course for Health Informatics, and after BSc Health Informatics 2-year course on MSc Health Informatics. They will find that very good job opportunity, much better
Yeah.
than even nurses and other lab technicians. And they will adopt technology, artificial intelligence, and by big data analytics. Even we are also promoting that clinical AI. These health informatics professionals will be in a position to do that. Today, a doctor gets into after MBBS gets into the primary health center and also animal primary health center. They are not being trained afterwards on technology. So with the clinical
Yeah.
AI,
They're not.
with the health informatics professionals, in the country we have about 45,000 primary health centers and about another equivalent amount of animal primary health center. Good job opportunity and throughout the world. So this Center for Health Informatics and Computing, I will also include as a core member with your vast experience, and also will develop that 3 years health BSc Health Informatics program course structure, and also 2 years MSc Health Informatics course structure, and 1 year PG diploma in Health Informatics course structure, and also 6 months diploma in Health Informatics course structure, to train lot of tribal boys and girls and also
Yeah.
rural boys and girls. That's why this university has given importance for 3 areas: agriculture, SMEs, and health.
Health.
And I wrote an article in 2004, Rural India to Shine, Smile, and Roar, based on the projects which I initiated when I was in government, at the grassroots level. And that was the, mission behind me. And I'm very happy to have the address by you, Dr. Suresh Sarvadekarji. And, is a very important topic: digital health informatics network value chain in tribal village. Case study from Palghar district, Maharashtra. And thank you very much. Please get associated, and we'll have an MOU signed between the Shobhit Institute of Engineering and Technology, and this university has, Shobhit University Gango has an Ayurvedic college,
Okay.
and running a degree program on Ayurvedic, and also that this naturopathy and yogic sciences, and with the it's a Center for Health Informatics and Computing in the Shobhit Institute of Engineering and Technology, and the this Ayurvedic college and naturopathy and yogic science college in the Shobhit University of Gango. And a person like you, the Center for Health Informatics and Computing can very well bring out MSc in Health Informatics and BSc in Health Informatics and PG Diploma in Health Informatics and Diploma in Health Informatics to complement and supplement the in the mission of to achieve the mission of holistic health
Yes.
at the grassroots level. Thank you very much. With this, I would like to thank our Honorable Chancellor, Honorable Vice Chancellor, and faculty members and the participants, and Mr. Manish Chapraji for making this program so successful, and above all, Dr. Suresh Sarvadekarji. Thank you very much. We will
Thank you,
close
sir.
the webinar and leave the studio. Thank you.
Thank you, sir. Thank you.